I guess I would begin with the definition. You probably get asked this a million times, but how would you define addiction?
Addiction means different things to different people and different researchers, and that's perfectly fine because there's lots of ways of thinking about addiction that are important. But what I found over the decades and still find with researchers as well as people who work in the field as practitioners and as people, lay people who have an interest in it, is that they get a little bit caught up in saying, well, this is the right definition, and your one is wrong. So one of the big debates in the field, which is not really a debate, is, should we be thinking about addiction as a dimension on which people can vary from being not at all addicted all the way through to being extremely strongly addicted, to thinking of addiction purely as a disease or a disorder of some sort. So unless you have these symptoms, then you're not addicted. Now, my view, for what it's worth, is that both of those have some kind of merit, but it's important not to get them mixed up with each other. So when we measure, for example, addiction to cigarettes, we tend the best measures, the ones that do the best job at predicting how people are going to be able to fare when they try to stop, which is what you really want to know, is how successful are they likely to be and do they need help. The best measure is, I think, well, there's one of them which is the Fagerstrom test for nicotine or cigarette dependence, and there's one that we use in my research group, which is the strength of urges to strength of urges to smoke scale, both of which are dimensional measures. You can go from like it's not a problem at all the way through to it's a massive problem. And what you find is that the higher you are up on that scale, the harder you find it to stop, and the more you benefit potentially from support and all the different treatments and so on. If we're being very precise about it scientifically, I would, and to stop, all this sort of unnecessary argy-bargy about it, I would call that addiction dimension. And an addiction dimension is a dimension which assesses the extent to which someone feels powerful urges to engage in a behavior that has the potential to cause harm and that has been learnt through experience with that behavior, because you need to distinguish addiction from excessive compulsive disorders or other kinds of things. I mean, they're related to each other, but they're not the same thing, and they need to be treated differently. So that's the dimensional side. And then on the other side, I would use the label addiction disorder, specifically if you want to talk about a clinical disorder of addiction, which would merit treatment, going into some sort of rehab or inpatient facility or even an outpatient facility, where in order to qualify for that, you have to reach a certain sort of threshold of problem, which wouldn't just be about the dimension side, which would be around sort of the strength of urges. It would be, for example, how much it's interfering with their life, how much damage it is causing or could potentially cause. Because in different, it's not that different from a lot of other sort of clinical conditions where you take into account a whole range of factors when you're deciding whether this needs treatment or not. Blood pressure being a very good example, where or statins or cholesterol being an example. So where you might prescribe someone with statins, even if their cholesterol's not that high, because they have other risk factors. In the case of addiction, you might want to treat addiction as an addiction disorder, even if, on the face of it, their strength of urges to do the behavior are not massively high, but it's interfering with their lives. It means that they can't hold down a job, or that it's interfering with their family life, or other things. So when we're talking about addiction, at the heart of it is this powerful motivation to engage in a behavior learned through experience with that behavior that has the potential to cause harm. But then we would want to divide that up into this concept of the dimension from which you can go from nothing to very high, and the disorder where you're saying if this is at a level that merits some form of clinical intervention. And there are various things that go along with the disorder thing, apart from the fact that it then merits treatment. You can get if you're in the United States, for example, you may be able to get your insurance company to pay for the treatment to help you recover. There's that, but also it means from a policy point of view that it triggers a public health response, which means that we're taking it out of the criminal justice system, or we're not just treating it as something that people do that's bad, and should be punished. We're treating it as a health issue that merits some kind of public health response. And all the evidence is across many countries is that those countries that treat addiction in the way that I've talked about, with this sort of dual thing of the dimension, but also the clinical disorder that merits treatment and a public health response, they do much better at keeping the level of societal harm from these kinds of behaviors down than countries that treat it purely as though it was a choice, or if it's something that's immoral or whatever. Classic examples being probably the best example I can think of being Portugal, who had a massive addiction problem, and then their public health guy sort of said, no, we've got to really do something about it. And he's completely switched their approach to a public health response, which is what they currently have. And they do still have problems with addictive behaviors, but it's nothing like what it was. And it's nothing like what we experience in countries like the UK, and let alone America, where in the United States, there's a very strong sort of law and order type approach. Addicts are bad people who should be punished and locked away kind of approach. And so I think that, thinking about it in these terms, it gives you a much better handle on how to address it successfully from a societal point of view as well as an individual point of view.
Thank you for distinguishing between the definition of the clinical term and the dimension. I think that's very useful. So what do you think makes the approach that Portugal has integrated so progressive and so effective?
I think it's the effectiveness comes from the fact that if you take a public health approach to this issue and you recognize that this is a behavioral problem that arises from an interaction between a person's environment, their life circumstances and their upbringing. One thing that's incredibly striking when you look at the history of people who get into difficulties with opiates or alcohol or other drugs is the extent to which they've had really problematic childhood experiences. I mean, it's very, very striking, and that's none of that's their fault, as well as the drugs themselves and the kind of effect that the drugs have on the brain, which we know, is it varies from person to person. It's not the same for everyone, but it can be incredibly profound. And their own sort of personal dispositions, which can make them vulnerable to, for a given level of exposure to a drug, to losing control and finding that they experience these incredibly powerful urges, which they really go beyond what they can manage. So if you recognize the breadth of the causal factors coming into play, and you say, our job here is is not to punish people because they're bad, but rather for all of our sakes, not just the people who've got addiction problems, but for all our sakes, to say our job is to minimize the damage that is done to society and to individuals by this behavioral problem, then that's what you get when the Portugal sort of type of policy is a broad policy. It's not, they're not saying it's not a problem, go and take drugs as much as you like. Quite the opposite. They're saying that what they're adopting is a rational, successful, evidence-based approach to minimizing the individual and societal harm from the behavior. Whereas in countries like the UK and the US, a lot of politicians, and the dominant theme is, addicts are bad people who should be punished, and that's the end of it.
I've spoken to quite a few people before I decided to do an interview with you, and some of them overcame addiction, and they actually wanted me to ask you this. So they wanted me to ask you, how does one know that they've successfully overcome addiction? Because some of them still get urges to take the drug or to abuse the substance, and they have this fear of relapsing, and they keep telling me, I know that if I even have a sip, or even if I have a little bit, I know that I'm back 100%.
Yeah.
So how do they know that they've successfully overcome addiction?
I think realistically, and this is kind of good news and bad news, right? Realistically, anyone who has got into serious difficulty with addiction has always to be vigilant, because the way the brain works when it learns something is, and then you change so that you're not doing it anymore. And it's not that it unlearns it. The brain doesn't unlearn things. So it's not like you can go back to where you were before you ever took the drug. What happens is that we learn we build a kind of layer on top of it that keeps it down. And the problem arises. The problem with that, the sort of bad news of that, is that in certain circumstances, sometimes it can be purely random. It can just come out of nowhere. Sometimes it can come out of stressful situations or life events. There can be various triggers. Or, sometimes it can come from you're just, with a group of friends and someone offers you a line of Coke or whatever it might be. And in a moment of weakness, you go, yeah, okay. It can be as silly as that. But what it means is that this sort of layer, inhibitory layer, we call it, on top of the addiction, which is working perfectly fine most of the time, can wear thin, or like the ozone layer. It can get eroded in certain situations, and then the behavior can break through if it's available. So anyone who's suffered seriously from addiction problem, I think pretty well all of the people you've spoken to would unfortunately agree with this, that they're always going to be potentially vulnerable, and that means that they've got to be vigilant, and that means that there will be certain times inevitably in their lives when they will be tested for whatever reason. And the best defense against that is to be prepared and to know that that can happen. That is going to happen. It's not a question of whether it's going to happen. It's a question of, when and in what circumstances. So you always have to be on your guard. The good news, I think, is that, that's not most of the time. Most of the time you don't, you're not thinking about it. It's not a problem for you. You're not experiencing these horrible urges and cravings that you've constantly got to suppress. That it's not like it was when in the first few weeks or months of coming off a drug or an addictive behavior. It's fine. So like many things in life, you can be you can just get on with your life, it's fine, but just in the back of your mind, always have this sort of vigilance and readiness with a prepared response should the situation arise, whatever that might be, that would, if it took you by surprise, would mean that you go, yeah, okay, and then you'd have that. You'd have that exposure to the substance again, which not inevitably, but in many cases would take you right back to where you started, which would obviously be disastrous.
Hmm. And in your book, you mentioned a lot of evidence that some people are simply born with fewer dopamine receptors, meaning that they're wired to get less pleasure from ordinary life and maybe more drawn to intense stimulation. Does that mean that some people are almost neurologically destined to seek out addictive experiences? And what do you think are the ethical implications of that?
Mm. Um, if I did say that, it's which I might have done. I think I would want to sort of be a bit more nuanced about it than that. I think that when we're born, we have a certain genotype, a gene. All sorts of things vary. Our eye color, our hair color. The height that we're going to be. There's lots of things that we talk about in terms of genetic determination. But what we don't really mean determination. Hair color can be changed. You can just dye your hair,
Yeah.
right? You can wear contact lenses and make your eyes that are one color a different color. Even things like height, not genetically, but purely because of better nutrition and so on, the world is getting taller. So when one talks about this sort of genetic influence on things, including behaviors, we're talking about one of the factors that comes into play that is good to be wary of. And one of the biggest of those, the absolutely massive, massive genetic factor in relation to behavior is sex, male versus female.
Mm.
Look at the rates of crime and violent crime and drug addiction and so on in men versus women, and you'll see, well, hang on a minute, there's something going on there. I'm not saying by any means all of that is genetically determined, but there is a very strong genetic influence. And we know that a big part of that genetic influence comes from testosterone, because testosterone has certain influences on our behavior that put men in particular at higher risk of certain kinds of behaviors because of the way it influences our motivation. It makes us less sensitive to punishment. We learn, men are less able to learn from punishment on average because of testosterone than women, and more reward sensitive. That means that, if you're doing, you get exposed to something and it's giving you some positive pleasure, whether it's a drug or some exciting, dangerous activity, then I'm being a bit oversimplistic here, but it's quite a striking thing, this sex difference. That it means that with more testosterone, you're going to be learning more from the reward part of it than the threat part of it, the danger part of it, and so you're more likely to put yourself at risk. That's one factor. But when it comes to addiction, as opposed to just engaging in a behavior which could be dangerous, then there are some general factors that come into play that you have as a vulnerability when it's not determined. It's a vulnerability which is worth looking out, being on the lookout for, related that are more general and some that are very specific to the substance. So, for example, with something like nicotine, then the rate at which you metabolize nicotine, particularly, is a vulnerability with regards to developing nicotine dependence if you're exposed to nicotine. Because if you're someone who metabolizes nicotine very rapidly, it's coming out of the body rapidly, then you can tolerate a higher dose. And so you can end up with a much higher rate of engaging in the behavior, which then can put you at risk of the kind of positive feedback loops within the particular part of the brain concerned that would lead you down the path of addiction. You see a similar thing with alcohol, where people who don't metabolize alcohol terribly well and get an adverse reaction to one or more of the alcohol metabolites have a lower vulnerability to alcohol dependence than people who can drink loads without getting hangovers and all the rest of it, because just the way that we learn things, if you're getting lots of positive reward and you're not getting enough negative reward, it can take you down this slippery slope towards engaging in the behavior to an extent that then results in problems coming off it. But then there are, on the general side, in terms of vulnerabilities, there are, we know that there's quite a strong heritability to anxiety and depression and mood disorders, which makes you vulnerable to certain addictions, because to the extent that those addictions appear, at least in the short term, to help you with those problems, you gain confidence, that sort of horrible feeling of anxiety or inner despair or whatever is numbed or disappears when you engage in the drug. That's going to be a factor. So what we're looking at then in terms of your sort of genetic makeup is that, as with hair color, eye color, height, lots of other things that appear to be strongly genetically, quote, determined, they're not really determined. What they are is, in the case of addiction, they're vulnerabilities. So if and because of this, because of the quite high heritability of nicotine dependence, alcohol dependence, and so on, all and other addictions, what it means is that if, for example, both your parents suffer from alcohol-related disorders or alcohol problems, then it really pays to pay attention to the risk that you might experience if you're not careful when you're dealing with that particular substance. And so I know people, I think maybe we all know people who have parents who got alcohol problems who steer clear of alcohol because they recognize that might be a vulnerability for them.
So I'm glad you actually mentioned this. This was one of my questions. So we know that children who grow up with an addicted parent often describe spending the entire childhood feeling hypervigilant, managing the parents' moods, and never knowing what to expect. But I wanted to ask you, with regards to the motivational system, what kind of damage or chronic stress does that do to a child's motivational system? And do you think that helps explain how trauma and addiction are so intertwined across generations?
Yeah, I mean, I would say that it's not massively well understood, but there are various plausible pathways. One, obviously, as you've sort of alluded to, is chronic stress and the impact that has. And I think the way I would think about it is to think about the different levels at which that might operate. So chronic stress at a very basic biological level does something to the way the brain works, and that can create a vulnerability when it comes to things down the line. But then at a level up from that, at a sort of a less biological and more psychological level, chronic stress can have all sorts of influences on your mood and the way that you see yourself, your identity, how you manage difficult situations. So it can take away your feeling of agency, your sense of being able to cope with things, your self-confidence and so on. So there's that level, all the way up through to the sort of your social interactions with other people, so that in an environment in which you're constantly being challenged and all sorts of things are kind of adversely affecting your sense of who you are and how you relate to people, then given that a lot of addictive behaviors take place in a social context, that you can see how plausibly addictive substances could help you, appear to help you to manage in those social situations. And then, of course, one thing leads to another, and you find yourself in difficulties. So I think there's multiple levels at which having poor or bad childhood experiences, whether it's abuse or other sort of stressors, can operate to create this vulnerability to developing dependence.
Mm-hmm. And I know that in your book you've also mentioned before that depression, anxiety, PTSD, and addiction co-occur together. So does that mean that addiction treatment that doesn't target the mental health aspect of things is only treating half of the problem?
Um, I think it kind of depends. I think in many cases that's correct. I think in many cases, if anyone who works clinically in the field of substance dependence, particularly opiates, alcohol, less so obviously things like nicotine, which are more kind of embedded in society and they still have a relationship with these vulnerabilities, but less of one. But particularly the serious addictions, or I say serious, they're all serious, but the ones that are adversely affecting people's lives in the moment. I think that yes, the existence of these comorbidities, as they're called, is so high that if you only treat, as it were, the substance dependence with methadone or with some kind of CBT or behavioral support or whatever it might be, and you don't help the person to fill the gap, fill the vacuum, or find other ways of managing the psychological and mental health issues that they've got, then I think the chances of lasting success are much lower. And that that isn't saying anything massively novel. I think that anyone who works in the field of addiction would be very familiar with that.
Mm-hmm. Would you say that identity development and identity work is also integral to successful recovery from addiction?
It does appear to be. I think that when we think about identity, it's worth thinking about it as broadly as possible, as any way in which you represent yourself as to who you are, what you look like, what you do, how you feel about yourself, and so on. So there'll be some specific aspects of identity that will play a role in your recovery from addictive disorders, including things like your confidence in yourself, your feeling of being sort of comfortable in your skin. But there is another factor, which is the specific sort of identity as an addict. I am an addict, and therefore, a whole bunch of things follow from that, including things like low self-esteem, and and a sort of fatalism around your addiction. This is not something I can take control over. And one of the ways in which programs like AA try and address that is to say, okay, yeah, okay, you are an addict, but you dissociate that identity, you are an addict, from what you can do about it. That doesn't mean there's nothing you can do about it. You are an addict. You'll probably always be an addict. This is the AA kind of thing. You will always be addicted, then you'll always be vulnerable. So, but you can move from this identity, let's say, alcoholic, I am an alcoholic, to I am a recovering alcoholic. And so when you're a recovering alcoholic, you're doing two things. You're saying, I'm not an alcoholic anymore in that sense. I am, but I'm not, but I'm always potentially vulnerable. So that identity shift plays an important structural role in the way that people can move. They can make that transition from the sort of fatalism that often comes with feeling like you're addicted to something, or in some cases, and we know particularly, for example, with alcohol, it's well known, that there are people who say, well, I'm not an alcoholic, I haven't got a problem, I don't know what what are you going on about? Yeah, I know I drink a lot, but I'm not addicted. So the identity there, the idea behind the sort of the treatment program is that you get an identity in which a person recognizes the nature of the problem. They don't deny it, but at the same time they don't adopt that sort of fatalism that would otherwise come with it. You've got this problem, but there's something you can do about it. You can transition to a new identity as someone who used to have that problem and now has a vulnerability to going back, but you've moved on. And one of the things you see even in cases like smoking, for example, is that when people make an attempt to stop smoking, those people who very quickly go from their identity as a smoker who's trying to stop to an identity as a non-smoker, or a former smoker. I don't smoke anymore. Yeah, I used to smoke, but I don't smoke anymore. Mm-hmm. That's a different identity, and they tend to be more successful than the ones who maintain the identity of a smoker. Oh, yeah, I'm still a smoker, but I'm trying to stop. That's not a particularly helpful identity. So there's lots of ways in which identity can play a role. And my own view, for what it's worth, is that from a psychological or a behavioral point of view, it's one of the things that we can really harness to provide a sort of overarching structure around that transition from being addicted to something to not anymore, even though there may still be a vulnerability. So I think it plays a potentially important role.
Would you say there's enough research evidence to back up the idea of using this label as a recovered addict? Is that effective, do you think?
Is there enough evidence? I don't think there's enough evidence on it. I think it's a hypothesis that has evidence to support it. I think it's not that there's no evidence. I think I would like to see more research done to. I don't think my own view is I don't think it's particularly in doubt that it plays some role in some people. What we don't know is how important a role and what you can do about it. And so, what would be really cool would be, some studies, trials and so on, in which they directly focus on the identity component as a core part of that. And the problem with doing these kinds of studies is that it's really hard to disentangle the different parts of a treatment program from each other, because you could never just do that. If you're providing help with someone stopping doing something, there'll always be some other components as well. And no one, or I don't think anyone's really going to fund a study in which you have a clinical trial in which in one group you have all the best treatment you can possibly imagine, but nothing to do with identity. And in the other group, you have all of that plus identity. I just don't think anyone would think it was worth the money to try and disentangle that. So we may never know for sure. But there's lots of things in, when we're forming policies and doing treatments and so on that we don't know for sure, but which we have a pretty good idea might be relevant and might be effective that we go with, because why not? You know, if you've got something, if you've got, let's say, a 60 or 70 or even 80% chance that something might be beneficial, and there's no reason to believe it would do any harm, then why not? You know.
I also wanted to ask, and I actually got asked this as well. What does the evidence say about what friends and family should and shouldn't do when they are trying to support their loved one who's struggling with addiction?
Right. Well, so interestingly, I was just reviewing a really, really strong paper that will be published pretty soon, I think, reviewing the evidence on the bidirectional nature of your social support networks and so on, and your social integration and recovery from addiction. And what the studies have found, and I found it pretty convincing what they were saying, is that it works both ways. So I think there is good evidence. I think I would say, you know, beyond reasonable doubt, that having strong, supportive social networks plays a role in recovery from addiction. But it's also the case that recovering from addiction improves your social networks. And so in an ideal world, what you'd want to do is to create a sort of virtuous cycle, a virtuous circle, where you have strong supportive networks, and in the treatment programs, you foster those. You know, you don't just sort of take them for granted, but you actually work actively to foster strong social connections, strong social relations, to help people through, you know, what is inevitably going to be a difficult period. But in the optimistic and confident understanding that as the person transitions to recovery status, that this will actually feed back into their social networks, and that will then potentially create a whole, you know, move the people from this very destructive kind of social environment in which they're operating, and, you know, often full of conflict and so on, through to a self-sustaining new social structure with people who value you for who you are, and so on and so forth. And that may well, in certain cases, mean essentially that you're moving away from people who themselves have addiction problems and aren't able or willing, or, you know, for whatever reason, are sort of still stuck in that cycle, to a new social environment in which that is less prominent.
And how do you think we should change our approach to the language we use? Because a lot of different words are being thrown around.
Yeah. I don't know. Let me think aloud on this with you, and then maybe I'll change my mind about it. I don't know. I feel a bit ambivalent about it, because on the one hand, I absolutely recognise that this way of labelling people like addict, alcoholic, smoker, you know, this kind of, it's almost like you're classifying a person in that way. That's what they are. But it's not what they are. It's something they do. And so, you know, it's like saying someone's a blonde or a brunette or what? So what? You know, I mean, you've got dark hair or you've got light hair. You've got blue eyes or you've got brown eyes. You know, there's so many different ways. It reminds me of the Monty Python's joke, which I think is very funny. Not everyone thinks it's as funny as I do, but the Monty Python's joke is there are two kinds of people in this world. I don't know if you've heard of this one. Two kinds of people. Yeah. Those who think there are two kinds of people, and the rest. And And it's like, yeah, you can classify people any way you like, and it doesn't make it sensible. So I would say that, I recognize that kind of language, that sort of classifying people in this way by what they do, you could eat, it is quite problematic. It's like driver pedestrian. Well, you're walking on the street, or on the pavement. You're not. It doesn't define you as who you are to be a pedestrian or a driver or whatever. It is something that you're doing anyway. On the other side, I'm also conscious of the fact that, what we know are successful programs like AA actually kind of take the opposite view in a way. They're saying you are an alcoholic. You've got to accept you're an alcoholic, and you will become a recovering alcoholic to the extent that you're successful. And so what is the benefit of that? If there is a benefit, I think it's what they're trying to do. I'll tell you what I think they're trying to do. They're trying to take people who haven't yet fully appreciated the severity of the problem that they've got. People, a lot of people who suffer from alcohol problems are in denial. They say, and they talk about getting rock bottom and all the rest of it before you finally come to terms with the fact that you've got a problem. And I think that's probably what's driving this idea that you should be labeling yourself in this way. However, against that, in this think aloud process, I don't see why that couldn't still work not by defining you as an alcoholic, but by saying, I've got a problem. I'm lots of other things. I'm a father, I'm a psychologist or whatever, but I have a problem. So I'm not sure that you need that kind of label to get the benefits of recognizing that you have a serious problem. I don't know. So those are my thoughts on it. I'm not sure that there's a huge amount of evidence one way or the other, but I think from all kinds of perspectives, including not just scientific ones, but also ethical ones, I think by and large, it isn't helpful to define people by one of the things that they do.
Yeah. And I personally was just thinking that, if they have come out to get help, they probably know that they have a problem already, right? So it's like...
If they've come for help, yeah, I would say. You would imagine. Yeah. unless they're only doing it because their doctor told them to, or their partner told them to, which can happen. It is true that that quite a lot of people, even now, people who come to when I started working in smoking, the people who came to stop smoking clinics were people who were desperate to stop smoking, right? So you didn't have to persuade them of anything. You didn't have to tell them that smoking was bad for them. They were already totally on board with that. And so your job in the smokers clinic was to help them achieve a goal that they had set themselves. Now it's not quite that, because a lot of people will come to smokers clinic because their doctor has said they really should stop smoking, and there's more ambivalence. And I think that is also true to varying degrees with other substance treatment. When people come into treatment, they're often there will be some who are absolutely on board with it. They know they've got a problem, they've got to do something about it. There'll be a fair number who have ambivalence about it, and there will even be some who think, well, I'm only here because my partner said I had to come, sort of thing. So I think it's worth remembering that.
Speaking of smoking cessation, I know you have years and years of experience, and you've done so much work on this. What was the most striking finding for you personally across those years of work on smoking cessation specifically?
The thing that really stuck in my head and I think has influenced my thinking ever since was right at the beginning, the first study I did back in the early 1980s, when and bearing in mind what I just said, the people who were coming in for treatment, they were desperate to stop smoking. I mean, they were really desperate,
Mm-hmm.
and and they were experiencing, many of them incredibly strong cravings. I mean, really, it's like, if you've never smoked and you've never become, you've never had this experience, you don't really know what it's like. I mean, this was, visceral. And they would describe it as almost like a hunger in the pit of the stomach, right? So they were experiencing these really strong cravings. And they didn't even enjoy it. They didn't enjoy smoking. And I remember thinking at the time, and I still think, when you crave, normally, when you crave something, it's because you think it's going to be fantastic. It's like, oh, I really could do with this thing. I'm really looking forward to this. This is something I really, really want. It's because your expectation is that it's going to be great. And that was so not the case with smoking. And ever since then, time and time again in the research, we've seen this dissociation between the enjoyment of the thing, of the cigarette, and the craving. And it sort of doesn't make any sense from a sort of common sense point of view, but it makes an awful lot of sense once you understand the neuropharmacology of nicotine and the way that nicotine acts on the brain. Because what it does is it doesn't care whether you enjoy it or not.
Mm-hmm.
It forges this link between the behavior and the sensations associated with the smoke going in the lungs, which normally you'd think, well, that's not pleasant, and this visceral urge to do something, and it completely bypasses the bit of the brain that would normally be involved, which would go, this is great. So one of the ways in which nicotine operates is to forge this very powerful association between the situation in which people smoke, the behavior of smoking and the sensations associated with it, the scratch of the smoke in the throat and so on, and this urge. And it just still, because it's so bizarre in a way, it still kind of baffles me. And if you didn't know the neurobiology of it, and you didn't know how it operates with the way that nicotine acts on the mesolimbic dopamine pathway and the nucleus accumbens shell and the core and so on, it would be baffling because it makes no sense from a psychological perspective. It only makes sense from a neuropsychological perspective.
Mm-hmm. I know we only have a few minutes left, and I want to end with a very open question.
Mm-hmm.
So, our favorite, politics.
Oh, politics, yes. Yes, well.
What would be your top 3 tips for the UK government about how to fight addiction in the UK?
Mm-hmm. Yeah, top 3. Well, the first thing I would say is that topically, depending on when this goes out, the Green Party have come under attack quite inappropriately and irresponsibly by people like Starmer and so on, who completely misrepresent their position as saying, oh, they want to legalize drugs and make it, so that, anyone can, get drugs whenever they like or whatever. That is absolute nonsense. It's not the Green Party's policy. The Green Party's policy is to treat it, as we talked about earlier in Portugal, as a public health problem. And in that way, the policy would involve a sort of multi-pronged approach, which I think would be appropriate, has evidence base and so on, and would benefit society. There would be fewer drug problems than we have now. But it sort of goes against this moralistic argument, oh, you've got to be tough on drugs and so on, which is idiotic, in my opinion. So the top 3 things. Number 1, treat addiction as a public health problem, not a criminal justice problem. That's not to say that the criminal justice system doesn't play a role or has no part to play, because it does, especially on the supply side, in terms of reducing the supply to people. But people who've got addiction problems have a health problem. Mm-hmm. Okay, so that's number 1. Number 2, recognize that just because a drug is legal, It doesn't mean to say it's less of a problem than a drug which is illegal, because the two drugs that are causing by far the most harm in our society are nicotine in the form of tobacco and alcohol, which even now our society has a ridiculously sort of jokey attitude towards. Oh, so and so got drunk. Yeah, that's not a good thing. Getting drunk, that is not good for your brain or your health or anything else. So recognize that you need to treat the so-called legal drugs with much greater seriousness. And fortunately, in the case of smoking, we're seeing at least a move in that direction with the smoke-free generation policy. So that's number two, the illegal versus legal. So first is public health. Second, really pay attention to the legal drug problems much more than are currently being done. And the third one, there's a number of candidates, but if I had to choose one, I think it would be to as a behavioral scientist, what one comes to the view of is that when you're dealing with a complex problem, you need complex solutions, multifaceted solutions. It's not a simple one stop, or one size fits all thing. So you need a strategy. And that strategy needs to be coordinated and involve all the different components. Back in the turn of the century, the UK government at the time adopted for the first time a tobacco control strategy, a proper strategy. And you can see very clearly on the prevalence figures there was a downturn. That's when the downturn started. Up to that point, things were looking really bad. And that's when we turned the corner. So having a strategy and refreshing that strategy and taking it with, as seriously as it needs to be taken with a multi-pronged approach, looking at all the different levers of behavior change that you've got, from education, persuasion, coercion, incentivization, things in the behavior change wheel, all the 9 intervention functions.
Yeah.
Think about it broadly as a multi-pronged strategy, and you will have a much greater chance of success.
Wow, that's very powerful. Thank you so much.
My pleasure. Great talking to you.
It was lovely to speak to you. Thank you.